Hi guys, thank you for joining tonight. We'll wait for a few minutes and then make a start. Okay, let's make a start then. Thank you for joining me tonight. Our session will be covering renal, and it is part of our finals teaching series. My name is Ashka. I am an F1 working at the Royal Liverpool Hospital. I'm also the president for Thursday 15, which is run by a group of F1s. So we hold regular teaching every Thursday to help prepare medical students for their final year exams. We've just passed our finals too, so we remember the type of questions that came up. So hopefully this session will be helpful as well. If you haven't been to one of our sessions before, the way that it works is that we go through all the questions first, and there'll be 15 in total. You'll have about 1 minute per question. I will be giving you a warning before moving on to the next question, which I saw on the feedback from last week. You guys would be happy to have that, so I'll do that this time. Yeah, so note down your answers and then we will go through them afterwards. If you've got any question, put them in the chat or the Q&A, and let's get started. All right, that's number one. Okay, we'll move on to the next question. All right, next question. Okay, next question. All right, next question. Next question. Next question. Next one. Next question. Next question. Next question. Next question. Next question. Next question. And final question. And that's it. Well done. We'll take a short pause, and then go through the answers. If you've got any questions, put them in the Q&A section or in the chat, and I've got my colleague who's going to help answer them. So we don't have to spend a lot of time at the end answering questions. Right then. So the first question is about a 60-year-old man who's an inpatient and being treated for possibly a pneumonia. You're the F1 on call, and you're asked to review the patient as he has only passed small volumes of concentrated dark colored urine over the last few hours, and his blood pressure is a bit low. You look at his urine output and it's less than 0.5 mils per kg per hour over the last 12 hours. And you see that there has been a creatinine rise to 220 over the last few days. So which stage of AKI is this patient in? I'll just launch the poll. All right, well done. So most of you have got the correct answer, which is C. It's stage 2. And the reason being that the urine output has been less than 0.5 mils per kg per hour over the last 12 hours, which is one of the criteria for a stage 2 AKI. And the increase in creatinine, so it's 2.2 times the baseline. So it's 220 divided by 100. 100 is the baseline. So 2.2, so that falls in the range of 2.0 to 2.9, which is stage 2. So AKI, rapid, so that means within a few days, and sustained, so it lasts for 24 to 48 hours, declined in kidney function, and this causes oliguria, so the patient passes less urine. In stage 3, it can cause anuria, and it results in a rise in urine creatinine. So this is the KDIGO classification. It's worth knowing it, and it's not very difficult to remember either. So stage 1 is creatinine rise of 1.5 to 1.9 times baseline, or a urine output of less than 0.5 for 6 hours. Stage 2 is 2 to 2.9 times the baseline for the creatinine, and the urine output is less than 0.5 for 12 hours. And then stage 3 is rise of a creatinine 3 times or more from baseline, or the urine output is less than 0.3 mils per kg per hour for 24 hours, or the patient has anuria, so they don't pass urine for 12 hours. So can you guys put in the chat, what are the 3 main categories of like AKI causes? Brilliant. Yes. So that's correct. Pre-renal, renal, and post-renal. So if you're in endoscopy and you get asked a question about what causes an AKI, it's good to structure your answer using those subtypes for causes of pre-renal, renal, and post-renal. So talking about pre-renal AKI, causes would be when you've got a reduction in the perfusion to the kidney. So this can be because there is a loss of blood volume. It can be because of systemic vasodilation. So for example, in sepsis, in anaphylaxis. It can be because your blood vessels supplying the kidneys are a bit abnormal. So for example, if your renal arteries are stenosed, so there will be less blood flow to the kidney. And it could be as a result of, say, heart failure, where you've got reduced cardiac output. The result of that is that you have a lower flow of blood to the glomerulus, and this leads to less glomerular filtration. And as a result, all your urea doesn't get filtered through to the kidneys. So you have a raised urea in the blood, and the same thing for creatinine. You also have a reduced urine output because, again, you don't get as much filtration happening. So there is a concept called the urea to creatinine ratio, and this is something that's kind of important to know about because it can help you distinguish between pre-renal and renal causes of AKI. So in pre-renal causes of AKI, you will have a raised urea to creatinine ratio. And if it's a renal cause, you usually have a low urea to creatinine ratio. Now, the reason that's the case is that in pre-renal AKI, you're not getting your urea and your creatinine when they're filtered. You're still able to reabsorb your urea, your nephron, so your tubules are still able to reabsorb part of the urea, but you can't reabsorb creatinine. Therefore, when you do the serum urea to creatinine ratio, it's going to be high, whereas in a renal AKI, you've got damage to the tubule, so reabsorption mechanism is affected, so you can't reabsorb urea. I think I might have said something wrong there. Creatinine is not reabsorbed in the kidneys, and that's why we use it as a marker of kidney function. Apologies if I said that. I was talking about the urea. So in pre-renal, it's only your glomerulus that's being affected. The blood flow in particular, your nephron is not affected, your reabsorption ability is not affected, so your urea can be reabsorbed. But in renal, the tubule is affected, there is damage, so that's why your urea cannot be affected, and then when you do the ratio, it's going to be low. Okay, so question number 2. You're asked to review a 58-year-old lady. She had an emergency laparoscopic cholecystectomy for acute cholecystitis. She's only passed about 50 mils of urine over the last 4 hours. She has a background of type 2 diabetes, hypertension, previous MI and GORD. You see that she appears dry on examination. She's a bit tachycardic and got a bit of a low blood pressure. There's a creatinine rise. So which medication should we suspend? Lovely. So most of you got it right, and it is indeed metformin. And can you guys put in the chat why it's metformin? Why do you need to stop it? Yeah, so lactic acidosis, that's right. So metformin itself, it's not going to cause the AKI, it's not going to worsen it. However, if there is someone with poor renal function and they are taking metformin, they are at higher risk of lactic acidosis, and this is why we stop it. So, there we go. So there is a mnemonic for the drugs that you should stop in an AKI. It's called the DAM drugs. Do you know what these stand for? Brilliant. Yeah, you guys are absolutely on top of it. Yes. So So the D is for diuretics, your A is ACE inhibitors, your ARBs, and your aminoglycosides as well, which is an antibiotic. Metformin and NSAIDs. Very well done. Now, a way to remember the mechanism for ACE inhibitors and NSAIDs, I learned that from a friend of mine. So this it's called PDA is ACE. Sorry about that. But essentially, PDA is prostaglandin, dilates the afferent arteriole. So this is the afferent arteriole there. So prostaglandins causes dilation. So that means there's more blood flow to the glomerulus. NSAIDs inhibit prostaglandins. Therefore, NSAIDs will cause the opposite effect to that, which is constriction of the afferent, therefore reduced blood flow to the glomerulus and a reduction in pressure gradient. So ACE, you have ACE, so the enzyme, it constricts the efferent arteriole. Therefore, ACE inhibitors will cause dilation of the efferent arterioles. And what this causes, again, is a reduction in the pressure gradient at the glomerulus and the Bowman's capsule. So that's my way to remember it. Metformin, it does not cause the AKI, but it can cause lactic acidosis when there is poor renal function, as we talked about, and then in a bit. But essentially, aminoglycosides, they're a form of antibiotics, and they can cause a renal cause of AKI, so acute tubular necrosis, and diuretics can cause acute interstitial nephritis, which is also a renal cause of AKI. Okay, so the next question is about a 55-year-old lady who presents to A&E with dyspnea, productive cough, and pyrexia the last 3 days. She's feeling more unwell, unable to pass urine. Again, you've got the odds there. She seems quite unwell from the high risk rate. She's pyrexial and tachycardic. You've done an ECG, and you've got her most recent blood results there as well. So you can see there that this lady is in AKI, probably because she's septic, she's unwell, she's got an infection. And you can also see that her potassium is very raised, which can happen when AKI gets quite severe. So given the above presentation, which of the following is the best way to cause an immediate reduction in her serum potassium level? So relaunch poll. Okay, well done. Most of you guys got it correct. The answer is C. So a lot of you went for calcium gluconate. Yes, if you were in a clinical situation and you saw this ECG, there you can see there's peaked T waves and everything. It doesn't look very good. The first thing you would do is give them calcium gluconate. You'd give them insulin dextrose as well. So calcium gluconate protects the cardiac membranes, okay? But it doesn't cause a reduction in the serum potassium level. What will cause that is if you give them insulin dextrose, and this will cause the potassium to move from the blood to intracellular. So that will cause a reduction in your potassium. calcium bicarbonate is not given in hyperkalemia, not early on anyway. IV antibiotics is not going to help here. And calcium resonium, again, this is not one of the first steps that you would do to help in hyperkalemia. Although calcium resonium does help to excrete potassium in some patients, so it can be used, but only with senior oversight. So what ECG changes can be seen in hyperkalemia? If you guys can put some in the chat. Yeah, total tented T waves, we saw that in the last ECG. Flat absent P waves, well done. Sine wave when it's bad, brilliant. Widened QRS, great. You guys are doing very well. So that's correct. So you can get total tented T waves, flattened P waves. You can get a prolonged PR interval as well, and then it starts getting progressively worse and worse. So you get a widening of the QRS, and then you start getting sine waves, and then this can eventually lead to VF or asystole, which is very bad. So management of hyperkalemia, so you treat if the potassium is more than 6.5 or there are ECG changes. So you give 10 mils of 10% calcium gluconate or calcium chloride over 10 minutes. So it's easy to remember 10, 10, 10, and it protects the cardiac membranes. Insulin dextrose, so insulin shifts potassium intracellularly, and you give the dextrose at the same time in order to stop the patient from becoming hyperglycemic. And nebulized salbutamol has the same effect as insulin in terms of moving potassium intracellularly. And then we've talked about calcium resonium helping with excretion, but it's not one of the first things that you would give. Next question, we've got a 50-year-old lady who is admitted in hospital, being treated for sepsis of unknown origin while awaiting investigation results. So she has a background of diabetes and high cholesterol, current medications are metformin, atorvastatin, amikacin, amoxicillin, and metronidazole. And you can see there that the urine output has been quite poor, and it is not improving despite supportive treatment with IV fluids. So given the most likely cause, which of the following would most likely be true? So relaunch, there we go. Okay, well done. So it's a little bit split, but most of you got the correct answer, which is D, muddy brown casts in the urine. So let's see. What do you guys think is going on here? What has this patient got? Yes, that's correct. So it's acute tubular necrosis. And so most likely from amikacin rather than the amoxicillin. So amikacin is an aminoglycoside. So it's one of those antibiotics, and it can cause acute tubular necrosis, which is a type of renal AKI. So here in this case, what's pointing you towards ATM is the fact that this patient is on an aminoglycoside and the fact that they've got quite a serious AKI, which is not improving despite supportive treatment with IV fluids. So that's kind of pointing you towards more of a, this might be ATM rather than pre-renal. In terms of the other answer options, a pH 7.6 on a blood gas would be incorrect. So you're more likely to get, not more likely, in AKI, you will get metabolic acidosis, not alkalosis, and this is because of an inability to control to maintain acid-base balance by the kidneys. Positive anchor, this is not really relevant in this case. We're not mentioning anything like the vasculitides here. Normal urea to creatinine ratio. So in this case, this is a renal cause, so we would expect a low urea to creatinine ratio, reason being that your nephron is damaged, so your kidney is actually damaged, so you can't get any reabsorption of urea. Muddy brown cast in the urine, this is pathognomonic, so that means it's very specific to acute tubular necrosis. So if you suspect that in a question, this would be the answer, or if you see that in the question, ATN is the answer. Now, low urinary sodium, it would be the opposite. You would get a high urinary sodium, and the reason would be because your kidney is damaged, so you can't reabsorb the sodium, so you would get more sodium in the urine. Okay, so ATN, quick summary. So it's when your tubular cells die, and this leads to a blocked tubule. As a result, there's reduced pressure gradient at the glomerulus, and for this and it just leads to an inefficient filtration and also to a renal AKI. So causes of ATN, it can be due to ischemia, so sepsis, hypovolemia, injury to your renal vasculature themselves, nephrotoxicity, so drugs such as aminoglycosides, rhabdomyolysis, lead ethylene glycol, acyclovir, and contrast can also cause it. Management would be to address the underlying cause. So, for example, sepsis, you would treat with sepsis 6 and remove nephrotoxic substance. Like, for example, in that patient, you would stop the amikacin. The thing is that ATN has quite a good prognosis because these cells will regenerate within a few weeks. So that's quite good. In terms of renal AKI, to kind of simplify it, you've got 4 main categories of like renal AKI. So it depends on which part of your nephron is affected. So if it's the glomerulus, you're more likely, what's more likely to affect the glomerulus is your glomerulonephritidise, which essentially just means inflammation of the glomerulus. This can cause AKI, but it usually presents as a nephrotic or nephritic syndrome, which we'll look at a bit later. The tubule is affected. We've talked about the acute tubular necrosis, and then interstitium, which is the bit around the nephron. That would cause acute interstitial nephritis, and it's usually caused by drugs. So NSAIDs, penicillin, acyclovir, diuretics, those are some of the common causes. And what happens in acute interstitial nephritis is that you get neutrophils and eosinophils migrating to the interstitium, causing inflammation, and you get this triad of rash, eosinophilia, and joint pain. And then finally, if you've got your renal vasculature being affected, so the vessels that are actually supplying the kidney tissue, and if that becomes stenosed, it can cause infarcts and it can cause damage to the actual kidney itself, and that can cause a renal AKI as well. Okay, so the next question is a 75-year-old man who presents to ED, worsening lower abdominal pain, inability to pass urine over the last 12 hours, Mentions that he has been experiencing painless hematuria over the last pain. Chronic smoker. On examination, suprapubic tenderness with a palpable mass. PR exam, unremarkable. The bloods show a raised urea and AKI. A raised urea and creatinine, which means that there is an AKI. So which of the following would be the best investigation to determine the underlying cause? Okay, so most of you got it correct, and the answer is D. Let me just end the poll. So the answer is D. So the reason is, let's go through the question. So they've got lower abdominal pain, they can't pass urine, they've been experiencing painless hematuria over the last few weeks. This is a red flag for urinary tract malignancy to begin with, denies dysuria, flank or loin pain. So you're not thinking about something, sure, it could be like it's acute retention, but it's not like something acute like a UTI or flank or loin pain, which would indicate like a renal stone or renal colic. The guy is also a chronic smoker, is quite elderly as well. So these are risk factors. There is suprapubic tenderness with a palpable mass. So the palpable mass, as you can imagine, is likely the bladder and the filled bladder, which can't empty. So if this patient had a kidney stone, which was, say, in the ureters or at the renal pelvis, you wouldn't get retention at the bladder level. Okay, a PR exam is performed. It is unremarkable. His bloods show AKI. What is the best investigation? So the urea to creatinine ratio is definitely not the best investigation. It gives us an idea, but it wouldn't give us an idea in a post-renal AKI anyway. Here we're thinking more like there's an obstruction along the urinary tract, and that obstruction is most likely to be potential malignancy because of the red flags that are present in the question. It's less likely to be a stone. This patient is not in acute flank pain or like having symptoms of, say, hydronephrosis. Urine MCNS would be if you were suspecting a UTI. That would also unlikely cause retention. A glomerulonephritis screen, so there is nothing in this question that would make you think about glomerulonephritis, really. So cystoscopy would be the best investigation in this case because you are suspecting cancer. Anyone, painless hematuria over the last few weeks, 75-year-old man, he's quite elderly, cystoscopy, 2-week wait referable. And if you do a cystoscopy, you'll likely find a mass in the bladder that's stopping him from emptying his bladder. So next slide. So post-renal AKI arises secondary to obstruction of the urinary tract. So the way that you can, again, kind of stratify it when you're talking or giving answers in an OSCE or in an exam, you say, well, there are, for anything really that involves a tube and an obstruction, you mentioned there's three things. So luminal causes, so like something inside it that's blocking it, like renal or ureteric stones, mural causes, so like strictures, malignancy, and extrinsic causes, for example, if they had, say, if they had BPH. Some causes to remember, because you will encounter those on the ward quite often. So if someone has an indwelling catheter, they can get blocked. So it's one of the very common reasons to be called to see a patient. And sometimes when you're on call, the catheters become blocked. Medications, anticholinergics, example, amitriptyline and calcium channel blockers can also cause urinary retention and obstruction. Okay. So the next question is about a 65-year-old man who's on critical care after surgery. He's very unwell, being treated for intra-abdominal sepsis. He's got stage 3 AKI, being treated supportively at the moment. However, which of the following would be an indication for acute dialysis in this patient? Okay. This is quite a split one. So most of you got the correct answer, which is E. However, some of you picked D, and we will go through them all, but essentially there are very specific criteria that kind of meet the indications for dialysis in an acute setting for a patient. And out of all of these, the last one is the only one that meets these criteria. So let's have a look at them. So the mnemonic is your vowel, so A-E-I-O-U. A stands for acidosis, so pH persistently less than 7.15, 7.2. This would be an indication for acute dialysis. If it's higher than that, even if they are acidotic, they wouldn't meet the indication for it. Electrolytes, hyperkalemia, so if you've got a potassium of more than 7 millimoles. So one of the answer options there was a flattened T wave, but in hyperkalemia, you would get a peaked T wave, not a flattened T wave. Intoxication, so poisoning, would also be an indication for acute dialysis. Edema, O stands for edema, but it's refractory pulmonary edema that we are talking about. So essentially, they've got edema, and you've tried to manage them, but it's not working. So then you have no choice. You need to put them on dialysis, and this is what the answer is for our question. Uremia with symptoms. So the patient has a very high urea in the blood, but they also need to have symptoms, so encephalopathy, so like confusion, or like pericarditis, if they describe like pleuritic chest pain, kind of, then that would make it an indication. But if it was just the raised urea, it wouldn't meet the indication. This is something that's very, very important to learn and remember, because questions do come up quite often about this in exams. So it's very important to learn it, like put in a flashcard or something and learn it. My advice. Next question. So we've got a 60-year-old lady who attends her GP practice for some blood tests and general health checkup. No record of any previous blood test results for her. The bloods come back as unremarkable, except for an eGFR of 59. Which of the following would confirm a diagnosis of chronic kidney disease? Paul? Okay. Okay. So well done. Most of you got the answer to this, which is B. Oh, there we go. So it's another EGFR of 59 in 3 months, and we'll go through the definitions in a bit. So E is definitely wrong because this is AKI, not this is a criteria for AKI, not CKD. Albumin to creatinine ratio of, so it's more than 3, milligrams per millimole. So for a diagnosis, you need your eGFR to be less than 60 for more than 3 months. So you only had one blood result in this question. You didn't have any other records of blood tests for this patient. So you can't compare to like their previous renal function and say that for sure, they've got CKD. Or if they've got markers of kidney damage, example, albuminuria, so your urine ACR, for more than 3 months as well. So 3 months is the key time frame to remember. So causes of CKD, very common causes, the top 2, diabetes, hypertension. And then you've got things like your glomerulonephritidis, your autoimmune diseases like SLE, congenital causes like polycystic kidney disease, and your nephrotoxic drugs. Symptoms of CKD can be very non-specific. Patients can just be tired and have pruritus, kind of feel sick, nauseous, frothy urine, edema. So a lot of the time, people won't know that they've got CKD until it's found incidentally on their blood tests. So these are some of the investigations that you do. So you've got the urine dip, the urine ACR, your blood, so your urinase is important, your FBC is important as well. Because CKD can cause anemia. CKD MBD is metabolic bone disease. Oh, sorry, I didn't mean to do that. Imaging, if you're suspecting, a structural abnormality that's causing a decline in the function. You can do a renal ultrasound, for example, if you were suspecting polycystic kidney disease, and consider renal biopsy. That's the way to diagnose glomerulonephritidis in the most basic kind of way. So management, you've got lifestyle. So you advise your patients about their diet, exercise, smoking cessation, alcohol intake. You manage the cardiovascular risk factors because cardiovascular disease is the leading cause of mortality in patients with CKD. There have been research has been done, and ACE inhibitors helps with hypertension in CKD. So it is first line in patients with CKD who have got hypertension. Anemia, you can start with iron replacement, and then you can also give them erythropoietin. So the reason why they get anemia in the first place is because your kidneys can't produce erythropoietin, sorry. And so if you replace that, hopefully it can help with that. And then you've got your renal replacement therapy options, which we'll go through a little bit later. But essentially, this is talking about your dialysis and your renal transplant. And this is your KDIGO classification for your CKD. Lovely. So, next question. We've got a 57-year-old man who presents to A&E new leg cramps and perioral numbness. What electrolyte abnormality do you guys think is causing these symptoms? And then he's got a background of CKD stage 3. These are the blood results, and here the question is asking which of the following has most likely led to the abnormalities on this patient's bloods. And yes, that's right. So hypocalcemia is the right answer as to what's causing these symptoms. Let's put the poll. Okay. All right, okay. So most of you guys got this correct. Well done. The answer is indeed B. I didn't like hyperparathyroidism at all as a medical student because it always confused me. And I had to sit down and really put my mind to it and think about how to remember it best. So parathyroid physiology, if you've got a low calcium in the blood, your parathyroid hormones will detect this and will increase the production of PTH hormone. This will act on your bone, increases bone turnover, so you get more calcium release into the serum. And then you've got your PTH, it increases calcium reabsorption and it increases phosphate excretion. And also you get activation of your vitamin D, which also helps with the function of the kidney and also helps with calcium and phosphate absorption. And as a result of all of that, you've got an increase in your calcium level in the blood. That's the physiology. Now, primary hyperparathyroidism is when you've got, say, in most scenarios, it's when you've got an adenoma of the parathyroid gland, which is releasing uncontrolled amounts of PTH. So you get a raised PTH, which leads to a raised calcium for this reason. And because the PTH will encourage phosphate excretion from the kidneys, you will get a low phosphate. In secondary hyperparathyroidism, which is what our question here focuses on, usually you will get CKD. It's usually because of CKD and vitamin D deficiency. So essentially in CKD, you've got damage to the kidney. You have a lower amount of 1-alpha hydroxylase level in the kidney, so you cannot activate vitamin D. Therefore, you have less absorption of calcium in the gut and less calcium reabsorption in the kidneys. So you get a low calcium and you also get a raised phosphate because the CKD causes impaired phosphate excretion. So all of that will stimulate further PTH release, which is why there is hyperparathyroidism. Now, tertiary hyperparathyroidism, is when essentially you've had secondary hyperparathyroidism for a while, so your parathyroid hormones have been producing PTH for a long time. They become so they become hyperplasia. So they increase in size, and then they release PTH uncontrollably, and this causes a raised calcium as well, and a raised phosphate because your kidney is still not working. Okay. So these are some of the common complications of CKD. So impaired fluid balance, which results in high blood pressure and edema, metabolic acidosis, hyperkalemia, high urea, and phosphate. Again, this is because you've impaired the excretion mechanism. Hematology, we've talked about the anemia. Musculoskeletal, we've talked, we'll talk a bit more about the CKD-MBD there. So it stands for mineral bone disease, but essentially it's what we talked about with regards to the secondary hyperparathyroidism, and then cardiovascular disease, as we mentioned already. So clinical features of CKD-MBD, you can get bone pain, deformity, fractures, and also poor mobility because of those investigations that you do. So usually you would ensure that patients who've got an eGFR of less than 30, they have these added to their blood test. So they need a bone profile, a PTH, and a vitamin D to check for CKD and MBD. And then the management is to reduce phosphate intake, phosphate binders, with regards to the hyperphosphatemia, vitamin D replacement, bisphosphonate, if it's required, for example, if they are osteoporotic, and then parathyroidectomy if they've got hyperplasia of the glands in tertiary hyperparathyroidism. So the next question is a 25-year-old man who attends the GP as has been passing blood in his urine for the last 2 days. So he recovered from a flu-like illness very recently. So urine dip is positive for protein and blood. So what is the most likely cause? Okay. Right. So as I expected, there is a split between B and E. So the correct answer is E. Okay. Now, the way that you kind of distinguish between the two is over the length of time that they've had the flu-like illness for. So for IgA nephropathy, usually it's at the same time. So they would have had like a flu-like illness over the last week. So like within the last 7 days, and they're now having hematuria. But if it was if the question said 2 to 4 weeks ago they had a flu-like illness, or even more, like 4 to 6 weeks ago, then you would be going for like post-streptococcal glomerulonephritis. But here in this question, it's over the last few days. So last 2 days hematuria, flu-like illness over the last few days, that's IgA nephropathy. Okay. Next question. The reason why it's one after the other is because I will be explaining both at the same time, because I've got a summary slide. So this one is about a child who presents with quite a lot of edema and facial swelling, and the urine dip is positive for urine, so which is the most likely finding on electron microscopy. Okay. All right. So well done. Most of you guys got it correct. So the answer is A. It's effacement of podocytes. So with regards to these kind of questions, I think the best thing to do is to, because you don't need to know these like these different types of like nephrotic and nephritic syndromes like in a lot of detail, but it's just important to like pick up on the keywords, on the key associations as well. And I've got all of that on a summary slide, which is coming up shortly. Before we go on to that summary slide, let's go a bit through nephritic versus nephrotic syndromes. So nephritic syndrome, so here you've got a diagram which kind of explains it, but you've got a triad in both of them. So in nephritic syndrome, you've got oliguria, so reduced urine, hematuria, and hypertension. In nephrotic, you have proteinuria, more than 3.5 grams per day, hyperalbuminemia, and edema. So the mechanism for which each of these happens, so with nephrotic syndrome, is because there is damage or injury to the podocytes, okay? So because of that, protein is able to get out and get into the Bowman's capsule. So you have a loss of protein, okay? Because you've got a loss of protein, albumin is a protein, any type of protein really, because so if you lose albumin, your liver will try to compensate and make more lipids, so you'll get hyperlipidemia as well on those patients' bloods. They are losing protein, so there's less protein in the blood, so the oncotic pressure in the blood is reduced, therefore they will have more fluid leaving blood vessels and causing edema. Antithrombin 3, protein S and C, they are also proteins and they are involved in your clotting cascade. So if you lose them, you're being predisposed to blood clots, so hypercoagulability. And then loss of immunoglobulins, this will put the patient more at risk of infection. Nephritic syndrome itself, this one is mediated by like immune complexes, so within the glomerulus, and these immune complexes will cause inflammation and damage to your basement membrane. Here, and this causes loss of blood cells into the urine. Now, if blood cells are lost, you will also get loss of protein because blood cells are quite big. So that's also something that's going to happen. So it's not just hematuria, there's also going to be some proteinuria as well in nephritic syndrome. Okay. So this is the summary slide that I was talking about. So it does look quite bulky, but it's just essential information that if you see in questions, it just makes it so much easier to like know the answer to. So like this is by no way an exhaustive list of conditions. It's just some of the common ones that come up in exams. So IgA nephropathy, for example, this is what you'd see on histology, and they would have a recent GI or resp infection in the last 7 days. And post-streptococcal glomerulonephritis would be 2 to 6 weeks post-resp skin infection, and you would have these raised anti-DNase B and anti-streptolizin O, low C3, and so on. So anti-GBM disease, so if you've got a question where you have a patient with hemoptysis and they've also got symptoms of nephritic syndrome, you think about anti-GBM, Goodpasture's syndrome. Alport syndrome, you've got this patient with nephritic syndrome, but they've also got poor vision and deafness, and this basket weave appearance under electron microscopy, that you're thinking more Alport syndrome. So and so on. We've also got one for lupus nephritis, and then for the nephrotic syndrome, so minimal change disease. So that question which we looked at right before, right before, a few minutes ago, that was a child with urine on his with protein on his urine dip, sorry. So it's the commonest nephrotic syndrome in children. There's a link to Hodgkin's lymphoma. You get a normal glomerulus on light microscopy, but there's effacement of podocytes on electron microscopy. FSGS, mostly in adults, most common, I think it's the most common in adults. There is a link to HIV, sickle cell disease, SLE, and this is what you see on light microscopy, and so on. Membranous nephropathy is also a common one that comes up. There's a link to Hep B and the subepithelial kind of deposits, which causes the spike endome appearance. So these are just like keywords that you kind of learn, and it kind of helps with your questions. And like your diabetic nephropathy, like this Kimmel-Steele-Wilson nodules, these are pathognomonic for diabetic nephropathy. Okay, next one. I'm sorry, it's dragging a little bit. I apologize. So we've got a 45-year-old lady, advanced CKD, managed with peritoneal dialysis. She has abdominal guarding on palpation, and her peritoneal dialysis fluid has appeared to be a bit more cloudy than usual. So what is the most likely organism that causes it? Interesting. Well, I like it. So it's very split, but the correct answer is actually Staphylococcus epidermidis. So if you've got peritonitis and peritoneal dialysis associated peritonitis, the commonest causative organism for that is Staphylococcus epidermidis. The others can cause it as well, but this is the commonest cause. This is also something, it's a fact to remember for your exam. So peritoneal dialysis is a form of renal replacement therapy. So you get the dialysate that goes into the peritoneal cavity. Your peritoneum acts as the semi-permeable membrane, and you get diffusion and exchange of solutes and fluids. So you've got the continuous ambulatory one, where the patient has to do it a couple of times a day. And you've got the automated dialysis, where it can happen overnight, which is quite practical for some patients. And then talking about the complications, there are also some catheter-related ones. So anything that goes into the body, there's a risk of infection. There's a risk of link, kinked, it becoming kinked, displaced, or falling out. Now, weight gain and erratic BNs in diabetics, because you're putting this dialysate in them, which has got glucose in it. So this can be a side effect or complication. Peritoneal membrane not functioning after a while, and then having encapsulating peritoneal sclerosis. I've seen this in a patient before. Essentially, when that happens, they can't have peritoneal dialysis anymore, and they have to shift to hemodialysis or transplant, sadly. So the next question is this 65-year-old man with end-stage kidney disease, and then during his first session of dialysis, he starts feeling unwell. So looking at his OBS, he is bradycardic, his BP is quite raised, and he starts breathing irregularly as well. So which of the following is the most likely diagnosis? Okay, I'll just wait for you guys for it to reach 50% and now stop. Okay, so again, there's quite a split in the answers here, but the answer to this question is actually disequilibrium syndrome. So let me explain what it is to start with. Apologies. So basically, if someone's having dialysis, hemodialysis for the first time, they're having quite a lot. So their blood is going out and going through this machine and then going back in. You, in this short amount of time, probably over about 4 hours, what's happening is that you're removing quite a lot of urea within quite a short time frame. So what happens is that this increases kind of the osmotic pressure in the blood, and so fluid moves from the intravascular space into your into the brain, and this causes cerebral edema. So cerebral edema, when it's quite severe, it can cause what we call intracranial hypertension. And as you can see there, underlined, so the bradycardia, the hypertension, and the irregular breathing. This is the triad, what we call Cushing's triad, which happens in raised intracranial pressure. So this is what's happened to this guy. It's his first session of hemodialysis as well. So it's quite it can be quite an experience with regards to all this urea all of a sudden, leaving body. In terms of Steele syndrome is when you get ischemia distal to your AV fistula in your arm. So it's mostly got to do with the arterial blood supply that's impaired distally to the AV fistula. Dialysis-induced hypertension is not a thing, but you can have dialysis-associated hypotension. That can happen, but not the other way around. And again, it's to do with how you're removing, like you're removing the patient's whole blood volume is going through this machine there and then going back in. So during dialysis, they can experience hypertension. So hemodialysis, form of renal replacement therapy, usually in the hospital setting, and it can go through an AV fistula or a tunneled central venous catheter. And then these are some of the common complications: nausea and vomiting, headache, complications associated with the fistula or the line, example, infection, Steele syndrome, or failure of the access point. And we talked about disequilibrium syndrome. Well done. So the next question is about a 50-year-old man with a background of kidney transplant for polycystic kidney disease, attending renal transplant follow-up appointment in clinic. Doctor notices gingival hypertrophy, but otherwise this patient as well. So which of the drugs has most likely caused this side effect? Okay. All right. Well done, you guys. Doing really well. So the answer is B, cyclosporin. So renal transplant. So I've got here, I've got some of the common like immunosuppressants and like their side effects for your information and for you to learn. Complications, so graft rejection, so you can get a hyperacute rejection, usually due to AVO incompatibility, and it happens within minutes. So during the operation, and then they have to remove the graft right then and there. Acute, so within 6 months. So that's usually for cell-mediated autoimmunity. And this can actually be treated by increasing the dose of immunosuppressants. So that can actually help with an acute rejection. But chronic rejection, which occurs after 6 months, even if you increase the dose of the immunosuppressants, it's not going to have much effect, sadly. In terms of early complications, you can have infection, bleeding, urine leak, so things that are associated with an operation. Late, you can have stenosis of the ureter, renal artery thrombus as well. And then we've got our immunosuppressant side effects, which you can go through in your own time. But tacrolimus, good to remember, cardiomyopathy, cyclosporin, good to remember your gamma hypertrophy, and prednisolone, which is a steroid, that's fine. And mycophenolate mofetil, think about myelosuppression. And azathioprine is not really used in renal transplant. It's more used in IBD and rheumatoid arthritis. So this next question is about a 30-year-old lady who presents with symptoms of a UTI. She has been trying to get pregnant. Urine dipstick is positive for UTI, sorry. Okay. Oh, is that still working? Yeah, it is. Okay. So, yeah, well done. Most of you got this correct. So the correct answer is nitrofurantoin. Reason being that, so basically, you need antibiotics. It's a UTI, so E is wrong. Amoxicillin is not usually used to treat UTIs. Ciprofloxacin can be an option, but this patient is trying to get pregnant, so it wouldn't be the first thing you go to. And then trimethoprim, you definitely wouldn't choose trimethoprim because, again, this patient is trying to get pregnant. So trimethoprim would cause like congenital abnormalities and things like that. So you wouldn't want that. Nitrofurantoin is safe, is the safest option in this case. So the next question is about a 62-year-old man who's presented and appears to be very unwell. He's got rigors, pyrexia. He's quite systemically unwell, and he's got severe pain in the right flank. Otherwise, he's alert, able to give a history. Urine dip shows leukocytes, nitrites, and blood. And then the question, read the question well, it says which of the following is the next best management option? The next best. Okay. So well done. Most of you got the correct answer, which is C. It's very important to read the question well. Now, in terms of UTI and pyelonephritis, what's the commonest causative organism, you guys? E. coli, well done. Yes, it is E. coli. So clinical features of a UTI, usually dysuria, frequency and urgency, foul-smelling urine, suprapubic abdominal pain, usually in a simple lower urinary tract infection, the physical obs wouldn't be affected that much, and the patient wouldn't be that unwell. But in pyelonephritis, this is when it goes to the kidneys and it affects the kidneys. Then you've got your vitals being affected and the patient is more unwell and there's flank pain and fever. Now, investigations, urine dip, MCNS, bloods, you do your usual basic bloods and blood cultures if they have a fever. If pyelonephritis is suspected, then you do a renal ultrasound scan. If you think about it, pyelonephritis is infection of the kidney. Some of you guys picked, what was the answer? Sorry. Right percutaneous nephrostomy. this is a procedure. It wouldn't be your next management option. Pyelonephritis is, first of all, an infection. The first thing that you do is you give IV antibiotics. That would be your first line option. That would be the next management step in that question there. Oral antibiotics can be given for a simple UTI. And then after you've started the IV antibiotics, then you can do the scans and see, oh, does this patient have a stone? Do they need stenting of the ureters? So if they do need stenting of the ureters, can I get a retrograde stent in, or do I need to like put an antegrade stent in, which is basically antegrade means with the flow of urine, so it's going in through the kidney. Usually you would only do that if the patient already had like a nephrostomy. Yeah, so you address the underlying cause after starting IV antibiotics, so surgical options and procedures. You don't do those first, and that is the end. And I apologize that we've run 7 minutes over. I would really appreciate some feedback, and I hope that it's been helpful. I will try to keep it shorter next time. But it's renal, and it's very difficult to get through in a short amount of time, because it took me a long time to kind of make my slides as well, because I was trying to understand everything again. So yeah, thanks for attending, and you're welcome. And thank you. I'm glad it was helpful. Feel free to email us if you've got any other questions. I won't keep you in here any further.
Ashka, there's just a couple of questions.
All right, yeah.
That were specific for questions.
Yeah.
Which I missed, unfortunately.
That's fine.
So someone asked, why not amoxicillin in this patient?
So
the question that was about. Was it about the UTI?
Yeah, so it was about the I think it was about the ATN question, so the acute tubular what is it, necrosis question. For that one, amoxicillin doesn't usually cause it doesn't cause ATN. Aminoglycosides are a common cause, but not amoxicillin. Was there anything else?
I think one was just, what's the answer to question 15?
The answer to question 15, that was the IV antibiotics, broad spectrum IV antibiotics, because the patient has pyelonephritis, and that would be the next best management option.
And I think one other person just said, sorry, can you repeat the answer to this question? If that person is still here,
which question is that?
Question? If not, no worries.
Okay, thanks for answering some of the questions, by the way.
No,
or most of them, really.
Thank you for doing the presentation. It was lovely.
Oh, thanks.
Amoxicillin in the pregnant lady. What has just come up on the questions?
Sorry, what?
Yes, amoxicillin in the pregnant lady. I'm not quite certain.
Okay. Was it an option? So the reason why it's not amoxicillin is because amoxicillin is not usually used to treat UTIs to begin with. I didn't really check about the use of amoxicillin in a pregnant lady, to be honest with you, but the reason why it's not the answer is because it's not usually it's not usually one of the antibiotics that's used for UTI, but I can quickly check for you in the BNF and see what they say. So amoxicillin, pregnancy. So it's not known to be harmful. So if it was like another question where they were saying, oh, how would you treat this lady's pneumonia, amoxicillin would work fine, but a UTI, you don't treat UTIs with amoxicillin.
Oh, okay. So we just seen that amoxicillin is actually second line in UTIs in pregnant women.
Really?
Yeah. Yeah.
So okay, then apologies. That's my bad. I should have done
It's
more
still
research.
second line, isn't it?
Yeah, it's still second line, it's not first line. That's why yeah, we don't see it that often either.
And then there's just another question, which is just in pyelonephritis, do you not want to decompress the kidneys ASAP?
Well,
no, I mean they don't generally, there's nothing really to decompress. Do you mean nephritis?
Yes, it actually depends on what the cause of the pyelonephritis is. So if it was like a kidney stone causing obstruction, hydronephrosis, and then infection, pyelonephritis, then yes, you do want decompression ASAP, but still IV antibiotics would be the first thing that you would do. And that's why that's the correct answer. But also to bear in mind that it's not always like an obstructive condition that's going to cause pyelonephritis. It can just be an ascending UTI. It might not have anything to do with obstruction, and in that case, you don't really need to decompress. In this question, question 15, it doesn't really mention here that this patient has got, loin to groin pain or like any mention of like kidney stones or like an obstruction. So no, you wouldn't. It's not the best managed. It's not the next best management option.
Yeah, and I guess it's decompression is never the treatment of pyelonephritis. It's the treatment for hydronephrosis, but you can have secondary pyelonephritis as a result of the hydronephrosis.
Yeah, exactly. That's what I meant. Yeah.
I think that's
it.
That's pretty much that.
Great. I'm really not a fan of renal. God. Oh my God.
Always the most complex.
Definitely not becoming a renal doctor or anything like that.
No, renal was the one where I accepted a lot of finals. So
yeah.
There were some really good questions, Ashka. So thank you for thanks for doing that. Oh, we should probably stop this because otherwise we're going to send.
Oh yeah, that's true.
A recording of just our conversation.
Yeah.
Okay.